So our final speaker this morning is going to walk us through a really important aspect of AI in healthcare, which is public trust and implications for policy and practice. Dr. Jodyn Platt is an assistant professor of learning health sciences at Michigan Medicine, who trained at in medical sociology and health policy. Her research focuses on issues at the intersection of informatics and ethics as she works to understand what makes data-driven health trusted, as well as the pathways for earning, achieving, and sustaining trust across stakeholders. Dr. Platt.
Thank you. I'm really excited to be here like everybody else in person. It's nice to see faces and three dimensions. I'm also sort of surprised and just observed that we have 3 out of 4 speakers with a background in social science speaking about AI. Which I think is an important sort of field of expertise to inform this emerging technology. So I'm going to sort of move a little bit so I can move. All right. So I really sort of divided my presentation into 3 parts. The first, I'm going to just sort of talk a little bit and sort of riff on this idea of trust and why it matters and why are we talking about it. It can be squishy, it can be ill-defined, but we all know that it's super important and that it's going to be a key element to AI. So we'll think a little bit right now about why is that true. And then I have a bunch of data from some research that's been ongoing over the last few years, basically surveying and doing qualitative research with the public and patients on the sort of the data infrastructure that's now driving AI and increasingly about AI itself and the use of predictive models in healthcare. So we'll spend a fair amount of time on that and then sort of conclude with what again is, I'd say, a developing framework that we're working on our research team to think about how might we be systematic in addressing all of these issues with AI that we've been hearing about all morning. Some of them are sort of the things that are familiar to us, but they're also sort of a big sort of list of things that we need to address as AI becomes an increasingly integral part of healthcare. So, things we know about trust. First, familiarity is something that really fosters trust. So if things are unfamiliar, like AI, like digital blah-bitty-blahs, that's going to perhaps raise skepticism among people. So becoming more familiar with technologies enables us to trust them and we can move on. We talked a lot about this morning about sort of if it's a 1 in a million thing, but you can generally sort of trust what's going on, it lowers our blood pressure and we can move on from there. So becoming familiar with things is going to be important not only for our clinicians and our health systems, but also for patients and the public. Second is that meeting or exceeding expectations is another place where trust can be built, right? So one of the definitions of trust is that trust is the expectation in another person and a willingness to be vulnerable to them so that they will perform a certain task. The willingness to be vulnerable to others for a given task. If that task is met, that breeds trust and we're willing to trust them again in the future. If they exceed our expectations, that's even better. It makes us feel good. And if they don't meet that expectation, then it may be okay. It may be that it just didn't work out this time, but they still have our best interests at heart. Mistakes happen. We're always at risk of something going wrong. We don't sort of live in a zero risk world. But to the extent we can meet or exceed expectations, that certainly helps us trust things more in the future. The third point is that trust, as well as mistrust and distrust, are rooted in real experiences. So it's not that people are completely irrational in not trusting others. And some of that trust is rooted in histories of racism and discrimination and generations old sort of things that have happened in the past that have led to bad things for families, for children, for adults, for everyone. So that if somebody's not trusting, it's not that they just didn't feel good. It's about a real experience. Next is that trust is relational and dynamic. So we're not sort of in a field of dreams environment. I think Dr. Wachter mentioned this before. We can build the best system in the world, but that won't necessarily make us trustworthy if we're not also sort of doing the work to create a relationship and to understand sort of what people's expectations are. Next is that trust is multidimensional. When we measure trust, we're often sort of looking at questions about competency, integrity, fidelity. Does the system, do providers have my best interest at heart? And that it's sort of a complex construct. And it can often, when we sort of talk about trust, sometimes we can talk about it sort of as a general thing, but sometimes it's also worth pushing the envelope a little bit and saying, well, what do we really mean by trust? Are we actually talking about comfort? Are we talking about just an ability to do your job effectively, or are there other sort of things going on there? Trust is related and highly gets sort of conflated with questions about risk, uncertainty, power, vulnerability, autonomy. So if somebody doesn't have a choice about being treated, for example, is that really sort of a trusting relationship there, or is just the trust built in another sort of context when you actually do have a choice about being with another person? And then ultimately, trust is providing us with a limited license. So if we can, again, sort of maintain expectations, manage them, meet them, exceed them, then that's a good thing. But if we're constantly sort of betraying those expectations, trust will start to erode and perhaps disappear. So one of the main sort of policy problems that I think we have in AI is that really right now our current rules don't necessarily align with public expectations. And so one of our jobs in building AI systems and building AI tools is going back to the policy environment as well as the public and the patients and all of our stakeholders, and figuring out what are the rules we need, what are the guideposts we need, and then what are the ways that we can sort of manage expectations along the way. So here comes the data part for those of you who are interested in that piece. I'm going to show you sort of some research that we've done looking at a few different sort of questions. And it's sort of the sort of high level, the data that will sort of implicate the fact that the public may not be the public is ready for a conversation because there is skepticism around the use of data and AI. So question number one, is the public comfortable with being a part of information sharing networks? So the sort of these sharing networks. Quick answer is not really. Would the public like to be notified about the use of health information? Yes. What data does the public consider sensitive when it's used in predictive models? What models raise concerns for the public? There are obviously sort of multiple types of models that we heard about earlier this morning. And then to think about some of what we know about what policies might emerge from this, what we know about how people are feeling and thinking about data and models. How would people like to be notified? And then what expectations, hopes, and concerns do we have? And then I'm going to present this sort of framework for how we might monitor risk for people and populations. So this data is basically from 2 R01 grants that we have from the NCI and NIBIB to look at patient and public attitudes about data sharing in the context of precision oncology, as well as data and use of artificial intelligence in clinical decision support. So most of our methods are mixed methods, so we do surveys of the general public, and we've done several of them over the last few years, as well as public deliberation methods where we get to bring people in for a full day or 2 days and really sort of talk to them about what kinds of solutions they would like to see around health information sharing. So question number one, is the public comfortable with being a part of information sharing networks? Again, that's sort of the short answer. But the way we asked, right, grumpy cat, it's classic. Am I comfortable having my electronic health information being a part of a network that includes other healthcare providers involved in my care, research networks, quality improvement, mental health, all healthcare providers in my state, and social service agencies? So we launched this question, again, sort of in that stage where we sort of looked at the way, electronic health information was becoming electronic, and as data is becoming increasingly interoperable, sort of the ideal is that our data is part of all of these. So we asked. And there are different ways of sort of looking at this data, but a couple of things I want to point out here. First is, again, depending on sort of how you want to sort of bifurcate the data, most people were comfortable with having providers involved in their care accessing their health records, although, again, might not be as high as you might expect. And the second is that the public is not making a differentiation between quality improvement and research. And again, from a policy perspective, this is important because the way we treat quality improvement and the way we treat research data is very different. We then looked at we generated an index out of the different levels of comfort with health information sharing, and we looked at the different factors associated with the comfort and information sharing networks. And again, just a few things to point out about these findings. One is that trust is related to comfort, not surprising, but true. That the variables in blue for me were one of the more important, interesting findings is that people with less education were less comfortable than people with higher amounts of education. People who felt that there's an obligation to participate in research and maybe be a part of health information sharing networks were more comfortable. And that people who are already confident in the way that we govern health information, and this was based on several questions that sort of got at this, are also going to be more comfortable with information sharing networks. And for me, this was important because these are also very often the same people at an institution that are making decisions about how health information might be shared. So it sort of points to the need to doing outreach to people that may not be comfortable and may not just sort of give you an automatic yes, let's just get all the data. We found an interesting sort of finding related to privacy, that privacy is sort of related to fears of harm and fears of being hurt by these kinds of systems. And so sort of getting at those kinds of concerns is going to be the places where we can both build trust, create safer environments, and create greater level of comfort that enable us to do the kinds of AI innovation that we want to do. So question 2 is, would the public like to be notified? And yes, and this is something that we've found consistently over many years and many different sort of applications, whether that's in large population biobanks, longitudinal cohort studies. People want to know about health information sharing and how it's being used, and they want to know simply and clearly. And I'll talk at the end a little bit more about sort of what that clear and simple, what some of those mechanisms might be, but in general, people want to know. So again, we asked a bank of 12 questions, trying to get at sort of are there any differences between whether health information is being used by commercial companies, some of those startups we saw at the beginning, whether it's being used by university researchers or quality analysts, whether it's identified or de-identified data, which again is sort of an important demarcator in the policy world, because de-identified data is often sort of associated with risk-free data. And that whether there's a difference between health information and biospecimens, which again can be treated differently from a policy perspective. And here's what we found. Hopefully you can sort of view the patterns here. But in general, people, again, they want to be notified. And there's a way in which all of these sort of questions sort of vary consistently. So they would like to be notified about all uses and all users. There's somewhat of a stronger preference for notification around identified versus de-identified data. Again, here we don't see a difference between quality improvement and research, nor is there a difference between health information and biospecimens. So we've sort of begun, and this is sort of our grant on looking at sort of the public attitudes around AI and clinical decision support is brand new. So our data is kind of brand new and we're still sense making. But part of the preliminary work we did for that was to ask questions about what kinds of data are people comfortable with being used in predictive models. So we asked, again, sort of to what extent are you comfortable with predictive models using information about all of these different things. So we asked about clinical data, blood pressure, cancer, health behavior. We asked about basic demographic things, age, sex, race and ethnicity, et cetera. And then some of the things that are being explored and examined in the context of social determinants of health. And here again, it's again what you might expect. It may be a little bit less comfort than you would hope for, certainly. And that may be related to this sort of not quite understanding what's going on with predictive models and being sort of reluctant to share. And yet, even if we're off by a bunch, it may not be quite as much comfort as you would want, or absent a greater dialogue. But clinical data, clearly there's greater comfort there, and some of the social determinants of health data is less comfortable. And then there's some interesting, I think, places in the middle, with genetic information being at about 40%. Again, sort of one of these areas that's been thinking about sort of what's the sensitivity and identifiability of genetic information. Marital status and zip code being sort of towards the bottom. And again, those are sort of classic social determinants of health data kinds of questions. So what models kinds of raise concerns for the public? Again, we talked a little bit this morning about what kinds of predictive models are out there and where will we be able to create innovation using AI. This is a nice, I think, graphic that shows that there are clinical applications and there are administrative applications that may be around predicting no-shows, predicting other kinds of operational kind of administrative applications. And so we asked, again, sort of a small handful of questions about comfort using predictive models. So the question was, are you comfortable with your provider using a predictive model to predict payment of medical bills, predict patients missing appointments? So those are sort of common administrative applications for AI. And then we also asked about kidney transplantation, sepsis, which is one that we use. It's out there already, predicting stroke and predicting colon cancer. And you can see pretty, I think, starkly that the administrative applications are sort of raise a lot of red flags here, but there's going to be some level of or greater comfort with clinical applications. Again, something to talk to people about, if not, something to start. This is what I hope is the start of a conversation with people. So I'd like to turn now to some of the, again, sort of where we're seeing policy implications of this kind of work. So how would people like to be notified about data sharing? And then what are the expectations, hopes, and concerns? And again, sort of to the extent trust is about managing expectations, but also our policies ultimately should be a reflection of the concerns and values of the public. And then we'll get into this framework. So again, the goal here being aligning rules with public expectations. So what rules need to be changed, what expectations need to be changed, and where's the middle line so we can wear matching socks. So how would people like to be notified? And so this is some of the results that we have from our public deliberations, where we talked to about 143 people across the state of Michigan. Overwhelmingly, we heard we should start with patient portals. And ultimately, we should be able to communicate with people in the ways that they want to be communicated with. Opting out, while may not be sort of an immediate sort of, it's hard to know how to operationalizing opt-out in some of these applications, but having some modicum of control is going to be important for public trust, I think. And that people, clearly, they sort of want something different than what we have now. So just a few takeaways. People want access that's convenient or at least not burdensome. So again, a few things that we heard. For me, I use the portal quite a bit, so access through the portal is going to be the best for me. Others say I prefer a phone call, but since this is the digital age, texting would be the next best thing. And then again, sort of a recognition across within our groups that there needs to be a point where it can reach everyone regardless of how they're able to access it. Most people were able to describe and talk fairly richly about the benefits and costs of allowing opt-out in these kinds of systems. So and people were conflicted even with their own selves. So my gut tells me everybody should have the right to opt out. My brain tells me that if we have that option, it's going to limit benefits to everybody. Others saying, I don't want people to opt out. I think that it will stunt the progress of medicine, and I want to take advantage because we all benefit from that. And then others who think it's really important to be able to opt out. I opt out because I'm in the opinion that you should always be able to make your own decisions on what happens and what doesn't happen with your healthcare information, my body, my choice, which I think is a really important sort of way of, we don't always think about it. We tend to disembody information, and it's not necessarily quite that simple. And that change is desirable, that currently we tend to speak in legalese. Who understands or wants to sit and read the HIPAA form? It's lawyer language. Even as a person in the medical field, I don't understand half of what they've written, and I feel like something should change. So again, some of the initial information that we've heard from folks about predictive models, just a couple of questions here. So one is, I think predictive models will improve healthcare, help people like me, benefit everyone equal, or harm people like me. Again, these are sort of places where if we can show the benefits, we can probably move the needle on some of these questions. And then I would want to know, again, people want to know. I would want to be informed, and then I do not want my provider to use predictive models. I'm comfortable with my provider using predictive models. There's some, both of these are related to trust in some of the ways you might expect. So one of the things we're starting to do is think about how might we be able to label predictive models for patients and the public. This is a prototype that we developed several years ago now. For this predictive model is probably more geared towards providers and clinicians than it is for the patients, although I think provides an initial good first step. So we're starting to look at some of this, and I think there's work all over the place working on labels and really trying to figure out what do we need to be communicating with end users about the use of AI in healthcare. And finally, I just want to end. This is again sort of it's a work in progress. So and I think it's an important one to sort of talk about and discuss among experts who are in this room and out there. But we're starting to think about, so what are the policy and ethical issues for clinical AI that need to be addressed to promote the health of people, so individuals as well as populations? And we need to sort of, again, examine AI from the moment it's sort of conceived and developed all the way through its deployment and implementation. So that's from development, design, and deployment. And if we look at public health, which has sort of long examined both sort of the implications of decisions for individuals, so weighing individual rights and individual interests with the health of populations and the good of society, and has sort of organized its work according to 3 core functions and 10 essential services, where we want to focus on with assessment, sort of how do we assess and monitor, diagnose, and investigate, what kinds of policies are we developing, how do we mobilize partnerships, and then what kinds of rules do we need to enforce, what does a competent workforce look like. We can begin to fill this table in with, again, any number of issues, many of which we've already talked about today. I'm just highlighting here the one I've highlighted in the last 25 minutes or so around the lack of awareness and interest among patients about data use. And then I think that once we've done that and sort of made, sort of come to a conclusion around what some of the issues are, then we can begin to engage stakeholders thinking about who has the highest interest in any given issue, who also has the power and control to do something about the issue that we've identified. and then sort of run those through the various ethical frameworks that we have available to us. And obviously in medicine, clinical ethics is an important part of medicine, but it's not necessarily an important part of AI in industry. And so developers that are out there may not have any background at all in understanding what does it mean for a patient to exercise autonomy? What does it mean to minimize harm and maximize benefits? And because we're sort of at this opportunity to have a conversation about the ethical values and principles that we're using to evaluate AI, it's also a really important moment to think about what might we be missing and using, even going back to our traditional values. So do we need to be sort of incorporating principles and ethics related to anti-racism and equity, and use that equity conversation to boost and empower sort of the AI space and create the system that we want to have, and not just the system that we have in digital form. And doing that, sort of going through that process of saying, okay, how are we going to evaluate and think about the issues? We can use those to then generate a list of solutions and understand the pros and cons and the benefits and risks of the solutions we do come up with. And again, this is a continuous cycle. So just sort of a couple of concluding thoughts. Clearly it's time to partner, engage with patients and the public now. It's a new technology. It's a squishy area for all of us, but it's sort of not too soon to engage patients. People do want to know, but again, I think our previous speaker talked about people are also really different, and there's a lot of variation out there. So how do we get to actually talk to everyone in the room? Trust is highly associated with comfort and safety and being able to create safe environments. And that's not a marketing message, right? Our BS meter can go off just as easily in any context, right? So making sure that that assurance of comfort and safety is real is important. Oh, I guess I'm done. I really am. All right. I have 4 minutes I still have a green light down there. But we have future studies that will examine context and the associations that will sort of dive a little deeper into the sort of high level frequency kind of data we were just looking at, and ultimately finding ways that we can hardwire safety and manage risk for people and populations to address health equity. And that actually is, you also can't see, I can see, but there's a thank you slide here for all of the people that are involved in this. And many of you are also here in this room, so thank you. It really is okay.
Very sorry about that.
It's okay.
If people have questions, please write them down on the note cards. We'll be collecting them. It seems like there's a bunch that have come in. I had a question for you. And I'm wondering about, a lot of the data that you presented was kind of general. Mm-hmm. I'm wondering if you've done some deeper analysis based on social determinants of health or race and ethnicity, and if you're seeing some differences in some of the responses that you're getting.
So yes, and yes. Although I will say that it's not just like, Black people don't trust and white people do. It's a more complex story than that. And it's also, I think, important. One of the reasons I didn't show it is that it is a more complex thing, that they're often sort of interaction terms that sometimes, it's also important. I think we have some good measurements of like experience of discrimination and showing how that's associated with sort of acceptance and also with withholding of information. So if people have experienced discrimination in the healthcare system, they're more likely to not even tell the right information, which again, if you're trying to collect data about what people say, So yes, we have some deeper dives into that.
Great, thank you.